Okay, we move on with the last part of this afternoon, 3 lectures. And I will kick off with a lecture on lactate kinetics, or lactate levels. I'm in a very special position, being a professor in 3 continents and 4 universities in the world. And what I experience in this practice is the different way people treat changes in lactate levels, initial lactate levels, dimensions in lactate levels. And so I'm very fortunate to have all these influences in how different people around the world, clinicians, deal with lactate. Possible conflict for this lecture only. Some of our research is sponsored by Maquette, that have developed or that have bought a company that developed a continuous lactate monitor measurement device. In a very recent systematic review, Jean-Louis Vincent took all the studies available that measured different lactate levels at different time points and looked at the prognostic value of changes in lactate in different clinical circumstances. And from this graph, you can see that you can have many time courses. I mean, your lactate can decrease rapidly to normal, but it can stay increased for some time and then trickle down. It can trickle down and then stay increased, something that you very often see in patients with severe septic shock. They decrease their lactate to around 4, and nothing changes much in the next few hours. And these have different etiologies, but in general, and that's what Jean-Louis Vincent in the study found, 96 studies, so that's a significant number of studies, and in every kind of patient. It's general ICU, it's surgical patient, post-cardiac surgery, sepsis, respiratory failure, cardiogenic shock, the whole mixed group of ICU patients that we more or less see around the world. And what did he found? If you decrease your lactate levels, you have a better outcome. If you don't decrease your lactate levels, you will have more organ failure, and ultimately a higher number of patients will die. And he also found that the changes are relatively slow in clinical practice. About 1 to 2 hours, so measuring lactate every 1 to 2 hours makes sense. Probably measuring lactate every 15 minutes, we don't know, there are no studies. And so with the continuous lactate monitor, we will do these studies, but at least as far as we know now, it's about 1 to 2 hours. And that's what we found in our lactate study that we published in the Blue Journal some years ago, where we looked at, does it have any value to use lactate as a resuscitation target? And we found that survivors tend to normalize their lactate levels in much higher percentages. What you see here is this is the survivors, and after 8 hours of initial resuscitation, this is admission to the ICU. This is 2 hours later, 4 hours later, 6 hours later, and 8 hours later. And you see that in the survivors, almost 60% have completely normal lactate levels, whereas in the non-survivors, it's just over 20%. And so this, let's say, absent normalization of lactate is a marker of severity of disease and of a patient group that has a higher incidence of mortality. That's also found in a review already done in 2014, where they looked at all-cause mortality and looking at lactate clearance. Now, lactate clearance is a somewhat difficult, at least we use it in an inadequate way, because we use lactate clearance as the change between time point 1 and time point 2. That's not really lactate clearance. At the end, I will show you some data on real lactate clearance, but that's changes in lactate levels. And so this is changes in lactate levels, and what he found is that the same with Jean-Louis' study. If you decrease your lactate, your chances of survival are higher than when you don't decrease lactate. And then we get this very strange phenomenon where we couple both. Like we did in the 60s, patients with shock have low blood pressure and they die. And so let's treat the blood pressure, and then they probably survive. And that's what he says here. In aggregate, our study demonstrates the higher lactate clearance predictive of lower mortality. So if you decrease your lactate levels faster, you'll have a better chance of survival, supporting the notion that resuscitation bundles involving lactate clearance may significantly improve patient outcome. Rubbish. Nonsense. Patients with low blood pressure that have a higher chance of dying do not necessarily, let's say, have benefit of increasing blood pressure. The same with glucose, the same with sodium, the same with potassium. I worked some time in Japan where we normalized everything. Every patient had oxygen, and every patient had oxygen to saturations of 100% because they said that's normal. And so if you normalize everything, they have the best chance of survival. That's not true. This is a very important paper to remember. Normalizing physiological variables in acute illness, there are at least 5 reasons to be careful about this. Intensive care is not about normalizing parameters. If that would be the case, then my cleaning lady can do the trick. I just tell her what to do, and that's it. Normalize everything. But it's the adequacy. You need an adequate blood pressure. You need an adequate cardiac output. You need an adequate pH. And in some cases, I'm very glad when the SCVO2 is 65% or even 50%. In severe cardiogenic shock, we accept very low SCVO2s as long as tissue perfusion is okay, the patient pees when there is no lactate. I'm very glad with low SCVO2s. But in the trauma patient with bleeding, accepting low SCVO2, never. And so it's about adequacy and not about normality. And you have to remember that by, let's say, normalizing stuff or treating patients like non-survivors, I mean, Shoemaker started this stuff, and we learned that that doesn't work. So normalizing values because the abnormality is associated with mortality, that's not the case. That may induce harm. That's what Michelle Hayes showed in her New England Journal paper when she started to treat patients like a survivor, inducing high cardiac output, high DO2, high VO2. She had increased mortality. That did harm to patients. Just like when we try to counteract the effect of iNOS expression in patients with septic shock with iNOS inhibitors. We increased mortality in these patients. So let's say normalizing stuff is not the goal. It's generating adequacy. But then again, I said, I mean, it's rubbish, but still he was true. Because when we did a meta-analysis, we published this last year in Intensive Care Medicine, we looked at all the studies using a change in lactate as let's say, a measure of adequacy of your resuscitation. So what you do is you treat your patient, and all these 4 studies, it's only 4 studies. All these 4 studies, what they did is they said if you have lactate, you have inadequate oxygenation. And so we treat cardiac output, we treat hemoglobin, we treat saturation. In the Janssen study, we treated also oxygen demand. So we put patients on a ventilator if they had increased work of breathing, for instance. When you do this, when you treat lactate as if there is tissue hypoperfusion, tissue hypoxia, and so you improve oxygenation, then you can see that on average you improve the chances of survival. You improve mortality. And so it's right. In this specific context, it's right. If you use lactate as an indicator to optimize your treatment, patients do well. And the Jones and Tian and Yu is 2 Chinese studies with a limited number of patients, and the Janssen study is the biggest, and we showed a 20% decrease in mortality. Now, what's the problem with lactate? Why is it so, let's say, indicative of mortality, and why is it maybe so limited when you want to use it in clinical practice to optimize your patient? Well, lactate, just to give you some physiology, lactate has two isomers, the D-lactate and the L-lactate. We measure L-lactate. D-lactate is mainly formed by bacteria, something that you only see when you have abnormal gut microbiome. So if you use a lot of Yakult, if you drink 1 liter of Yakult, you probably make D-lactate. In general practice, lactate is dissociated, so lactic acidosis is a very difficult concept because the pKa is 3.8. At the pH of 3.8, we're all dead. And so there is no lactic acid. There is lactic-associated acidosis, but no lactic acid in our system. The metabolism of lactate, and that's, I think, the most important thing, it comes from glucose. And when glucose is metabolized, there is a small production of ATP. It's only 2 mole for every mole of glucose. And this system is enhanced by phosphofructokinase. Remember that, because I will come back to that. And so from every mole of glucose, you will form 2 mole of pyruvate and 2 mole of lactate, and energy, 2 mole of ATP. Now, the oxidative phosphorylation is something that we are more interested in because in this case, you make 36 moles of ATP. So a very efficient energy, let's say, factory, but in addition, a very slow process. And so the process of the Krebs cycle is much slower than of the glycolysis. And so if you're in need of immediate, So if you're in need of immediate energy, then this reaction will be more prominent. And you will rapidly metabolize glucose, and this speed can increase up to 1,000-fold. And so you have a rapid metabolism of glucose and a lot of ATP, but also a lot of lactate, because you will start to accumulate pyruvate, and it takes much more time to, let's say, metabolize the pyruvate in the Krebs cycle, and so you will generate ATP. And so if you increase pyruvate, by definition, you will increase lactate. Is that true? I don't know why it doesn't go to the next. Yeah, okay. So if you infuse a substrate, you will start to make lactate. Well, that's true. That's already in 1958. This is an infusion of pyruvate. And so remember, the Krebs cycle is slow, so if you add a lot of pyruvate, you start to generate lactate, and that's true. You infuse pyruvate, an immediate increase in lactate. You stop the infusion of pyruvate. Pyruvate gets metabolized, lactate is metabolized in Cori cycle, and you see an immediate decrease to normal in your lactate. And this time frame is about 20 to 30 minutes. So a very rapid metabolism in normal circumstances. As I said, phosphofructokinase accelerates the metabolism of glucose. Phosphofructokinase is pH dependent. In alkalosis, it gets stimulated. And so if you hyperventilate, you will stimulate your phosphofructokinase. You will increase your glucose metabolism and your lactate goes up. If you hyperventilate, your lactate goes up. If you stop hyperventilating, your lactate goes down. You start hyperventilating again, your lactate goes up. And so in respiratory alkalosis, you will find lactate. Nothing to do with tissue hypoxia or tissue hypoperfusion. If you increase glucose metabolism in another way, and a very efficient way to increase glucose metabolism is give epinephrine. If you give epinephrine to a healthy person, they will increase their lactate in a dose-dependent way. So this is the dose, the concentration of epinephrine, and this is lactate. And so if you give more epinephrine, you get more lactate. And so with epinephrine, you stimulate your sympathetic nervous system, you start to metabolize glucose much more rapidly and generate lactate. Another way to increase your glucose metabolism is give steroids. This is a dog experiment in a veterinary journal a few years ago, and they gave a lot of steroids. 1 milligram is more or less normal, but 4 milligrams is a serious dose of prednisone. And as you can see, this is day 4. So 4 days after the start of the steroids, you have an increase in lactate, and at day 14 in the high dose, you have a very significant lactate. Remember, a lactate of 4 in clinical practice is associated with 50% mortality. It was in the time of Maxari Weil 50%. We redid the study a few years ago. It's still 50%. And so this is significant lactate, but has nothing to do with tissue hypoxia. These dogs are not in shock. These dogs have enhanced glucose metabolism. When you induce a metabolism that is very dependent on ATP generation, like the sodium-potassium pump, very dependent on ATP, if you accelerate the sodium-potassium pump, you will start to generate lactate. It's nothing to do with tissue hypoxia. If you block the sodium-potassium pump, like in this study by Bruno Levi with uabain, some kind of digoxin, it blocks your sodium-potassium pump, and you see that you get an immediate decrease in lactate levels. Now, these patients already had more or less normal lactate. And so this is significant lactate, but has nothing to do with tissue hypoxia. These dogs are not in shock. These dogs have enhanced glucose metabolism. When you induce a metabolism that is very dependent on ATP generation, like the sodium-potassium pump, very dependent on ATP, if you accelerate the sodium-potassium pump, you will start to generate lactate. It's nothing to do with tissue hypoxia. If you block the sodium-potassium pump, like in this study by Bruno Levi with uabain, some kind of digoxin, it blocks your sodium-potassium pump, and you see that you get an immediate decrease in lactate levels. Now, these patients already had more or less normal lactate levels. This was stable septic shock patients. But this is confirmed in many animal studies. And so the very ATP-dependent pump starts to generate lactate in the absence of tissue hypoxia. And that's how we use it, because I think there is no doubt that tissue hypoperfusion and tissue hypoxia is bad for your patient. It will result in organ failure and ultimately lead to increased mortality. And so this is what you have seen in the previous presentation as well. If you decrease DO2 by any means, either by decreasing oxygen, by decreasing hemoglobin, by decreasing cardiac output, by taking blood away, so hemorrhage, or by increasing the pericardial pressure, by inducing tamponade, it makes no difference. This is a tamponade model that I developed together with Haibo Zhang when I was in Brussels. You decrease cardiac output, VO2 remains the same, lactate doesn't change. So basically not really a shock model. When you reach this critical point, then you see the decrease in VO2 and the increase in lactate. And remember, in this stable dog, this is the required amount of oxygen metabolism to maintain function. That's baseline. And so if you start to decrease oxygen consumption, well, you didn't do anything on oxygen demand, that by definition is the best way to define tissue hypoxia. You're not using adequate amount of oxygen to maintain normal function. And so in this model, in every model, this is associated with increased lactate levels. Also in patients, there's very limited data. Well, actually there's only one study by Juan Ronco in the JAMA a long time ago. And these were not normal patients. He stopped treatment in these patients, and measured DO2 and VO2 while the patient was dying. So they stopped mechanical ventilation, the oxygen, dobutamine, norepinephrine. And so this was, let's say, an end-of-life experiment. And during the experiment, they measured DO2 and VO2. But I think you can appreciate the same curve as in the experiment that we did with Haibozang when you induce tamponade in a dog. That was a dog model. So this dependent phase and reduced oxygenation, oxygen consumption, and normal oxygen consumption while the DO2 is decreased is also present in patients. When I was in Brussels and did my PhD a long time ago, I looked at all the studies that measured DO2, VO2, and the dependency of the two, so the slope and lactate levels. And at that time, increased lactate levels were, let's say, associated with this dependency, so read shock. Many years later, Gilberto Friedman, also in Brussels, looked at during resuscitation in patients on this relationship. And as you can see here, this is the slope where the VO2 goes down when DO2 goes down, or the other way around, because this is resuscitation. So they increased oxygen delivery with treatment like dobutamine and fluids, and you see an increase in VO2 associated with abnormal lactate levels. In the later stable phase, you increase DO2 and nothing happens to VO2, and there is normal lactate. And so this basic mechanism that we see in animals is absolutely there in patients as well. And then how we use it, increased lactate is tissue hypoxia. That should mean that if you resolve tissue hypoxia, that the lactate should disappear. This is the study that the first study that we did in Brussels with Haibo. In this tamponade model, we induce tamponade. So we create, from here, we create shock, and you see an increase in lactate to around 4. Remember the number. And then we remove the tamponade. So that's basically treatment of shock. And so basically we went the same way. A little bit difference in oxygen, critical oxygen extraction, not important for this talk. But when you went up, and so increased cardiac output again, lactate decreased. And when we went back to normal, lactate was back to normal. So yeah, in this model, where there is real tissue hypoperfusion and hypoxia, lactate is a very good marker of the resolving issue in these patients. Now, is this true when you resuscitate septic shock patients? We did a study in survivors. So all these patients survived. And what we did is we were interested in this, let's say, resuscitation phase of sepsis, and whether the same, let's say, tamponade model is applicable to sepsis as well. So I treat sepsis, I increase DO2 because I give blood, I give oxygen, I give dobutamine, I give fluids. You do all these things in these patients that improve your oxygen delivery, and then lactate should fall. And as you have seen in the animals and in the very early studies, it should fall quite rapidly. But then there is, in sepsis, as I will show you later, a metabolism problem. There is increased glucose metabolism. There is decreased pyruvate clearance. And so maybe later on, there is no relationship between flow, increasing flow, and rapidly decreasing lactate levels again. What we called the flow-dependent phase of lactate levels. So 31 patients with severe septic shock, Apache 24, and a SOFA of 10, 11, that's a significant severity of illness. And basically we found what we thought that we should find. There was a phase, and this is the normalization ratio of lactate, just like INR. And this is lactate. This is lactate, and this is the delta PCO2. And as you heard in the previous talk, the delta PCO2 is a very nice marker of flow. And what you see is the time resolution is dramatic. I mean, the time resolution is 6 hours, 12, 18, 24. With the continuous lactate catheter, we hope to be much more precise. So this is very rough. But what you see is that early on, you rapidly improve flow because of a rapid decrease in your delta P CO2. What you see at the meantime is a very rapid decrease in your lactate levels. And then it starts to trickle down. It doesn't normalize that fast anymore, just like the difference between arterial and central venous CO2. It doesn't normalize that fast anymore after your initial resuscitation. And so we said, in septic shock, there is a phase where lactate absolutely tells you that improvement, that let's say the decrease in lactate level is the result of your improved tissue perfusion, tissue oxygenation. But there is a phase where lactate is not indicative of that anymore, and where lactate is telling you that something wrong, there is something wrong in metabolism. And then we come to lactate clearance. And lactate clearance is you give lactate, a bolus, and then you see what the patient, or in this study, the sheep, do with this exogenous lactate. And so that's the capacity of the sick or the control animal to do something with your lactate. This is a study we just published. We did in Santiago, in Chile. We did laparotomy, and then we to put in probes for portal vein and hepatic artery flow measurements, to put in probes to measure oxygenation in the muscle, lactate and mitochondrial function and stuff like that, and to introduce sorbitol clearance as a measure of portal blood flow, hepatic blood flow, sorry. And then we had either the sham animal that served as a control, and this is a continuous infusion of LPS. This is a very sick model. At the end of the experiment, we needed a lot of norepinephrine to keep these animals alive. It's the model that Arnaldo Dubin made in Argentina, and we copied it. And so after the volume fluid resuscitation, we started a bolus of lactate, and then measured the disappearance of lactate clearance. Now what you can see here is that this is the lactate clearance at baseline, this is the control, and this is the septic animal. And as you can see, after fluid resuscitation, boom, zero. There is no lactate clearance anymore. While the liver perfusion is completely normal, and the clearance of sorbitol, and that's also a metabolic thing, it's an alcohol sugar, and it needs to be metabolized by the liver to measure flow. It's a little bit out of the scope of this talk to go into that, but it's a measure of liver function, metabolism of an alcohol sugar, and perfusion. It's completely normal. So the liver is able to metabolize one, but not B, not lactate. And nothing changed, so there was no restoration, and it's close to zero. It's about 2%. Now, we thought that in septic shock, the sympathetic activation, which is present in critical conditions, might be related to this limited clearance of lactate. And so we studied the effect of dexmedetomidine, an alpha blocker, and the effect of a beta blocker, esmolol. And so the idea was to block the sympathetic nervous system, or partially block, because we used heart rate to dose the esmolol, and we used fixed doses of dexmedetomidine. So we didn't measure sympathetic nervous system and, let's say, blocked it to almost zero and then looked at lactate clearance. We used the, let's say, clinical indications or dosages of both dexmedetomidine and esmolol, and we found a significant effect. Absolutely, and a very big significant effect. So almost double. So the lactate clearance almost doubled. But then again, it doubled from 2% to 4%. or 3 to 6. Well, that's clinically completely irrelevant. So although dexmedetomidine and esmolol had a very significant effect on lactate clearance, the clinical effect is almost zero because it remained incredibly low. And so there's more than only sympathetic nervous system activation. So in conclusion, changes in lactate levels following your initiation of treatment are associated with mortality. If they go down rapidly, you have a much better survival. And therapy aimed to improve tissue perfusion and oxygenation, so treat lactate as if you have tissue hypoxia and tissue hypoperfusion. They are, in the early phase, associated with improved outcome. And remember, the randomized study using lactate lasted for only 8 hours. After that, we stopped resuscitating on lactate levels. And so we don't resuscitate on a persisting lactate of 4 on day 2. At least not with improving circulation. Changes in lactate levels are significantly confounded by changes in metabolism and clearance. And so when lactate does not decrease after you started treatment, so nothing happens, then rethink what you're doing. That's probably one of the major effects that we found in the lactate study. When nothing happened, when you increase cardiac output or hardly anything happened, we rethought, do we give the right antibiotics? Are we sure that this is septic shock? Are we sure that this is pneumonia and not an intra-abdominal sepsis? Shouldn't we do a CT scan to make sure, or an echo, to make sure we are on the right path? Shouldn't we do an echocardiography to see whether all that we have done resulted in real effect in the heart? And so rethink. And I think as far as we know now, I think it's important to measure lactate levels frequently. Every 1 or 2 hours. In the lactate study, we aimed for 20% decrease every 2 hours, so 10% per hour, but only in the early phase. I don't think it's necessary to measure lactate every 2 hours on day 2. That wouldn't give you other information than severity of disease, but wouldn't help you to resuscitate your patient. Thank you.